Let's move on to the physiology portion of this lecture, and we'll begin by returning to the HPA concept. Some of these relationships are quite clear. CRH stimulates release of ACTH, GHRH stimulates release of GH, and GnRH stimulates release of FSH and LH. There are a few relationships that are a bit more complicated. TRH acts on TSH, as we would expect, but TRH also promotes prolactin release. The negative regulator of prolactin is dopamine, which is constitutively released, and prolactin itself is a negative regulator of GnRH. This blockade of GnRH is the reason why women who are breastfeeding do not ovulate. Finally, we note here the effect of somatostatin, which, as we mentioned, comes from the delta cells in the pancreas. Somatostatin blocks the release of GH and TSH from the anterior pituitary. We went through the information on prolactin a bit quickly, so let's take a closer look now at this diagram on prolactin regulation to make sure we understand all its intricacy. As you can see, there is both negative regulation from dopamine and positive regulation from TRH. Prolactin, once secreted, actually upregulates dopamine production, which feeds back to inhibit prolactin secretion, thereby maintaining homeostasis. Prolactin inhibits GnRH and is also responsible for stimulating milk production in the breast. There are some drugs that interact with prolactin that you should be familiar with. Bromocriptine is a dopamine agonist, and therefore it inhibits prolactin. This drug can be used for treatment of prolactinoma, which is the most common type of pituitary tumor. On the other hand, dopamine antagonists, including most antipsychotics and estrogens, such as oral contraceptive pills, stimulate prolactin release. Growth hormone is released in a pulsatile fashion in response to GHRH. Secretion is higher during exercise and sleep and is inhibited by glucose and somatostatin. Growth hormone promotes linear growth and increase in muscle mass via somatomedin secretion. Interestingly, growth hormone is diabetogenic because it increases insulin resistance. Pituitary adenomas that secrete excess amounts of growth hormone can cause acromegaly in adults, which is after growth plates have fused, or gigantism in children, which is before growth plates have fused. The layers of the adrenal gland were discussed in the anatomy section, and now we return to the adrenal to look in more detail at the chemical reactions occurring in the different zones. First, let's remind ourselves of the layers in the adrenal cortex. GFR for zona glomerulosa, zona fasciculata, and zona reticularis. As we mentioned with the mnemonic, the deeper you go, the sweeter it gets. As you move deeper into the adrenal, you go from salt to sugar to sex hormones. The second thing we'll do to familiarize ourselves with the diagram is to look at the starting and ending products. We begin at the top left with cholesterol. These are all steroid hormones, and cholesterol is the building block. Now let's look at our products. Aldosterone from the zona glomerulosa, cortisol from the zona fasciculata, and testosterone from the zona reticularis. You can see here at the far right that testosterone and its precursor, androstenedione, can be peripherally converted to the other sex hormones, including estrone, estradiol, and dihydrotestosterone or DHT, which is a more potent androgen than testosterone. Now that we have a sense for where we are starting and finishing, let's take a closer look at how we get from one molecule to the next. If cholesterol is just sitting in the adrenal cortex, it doesn't have any motivation to change. What it needs is an enzyme to catalyze the process, desmolase, and that enzyme must in turn be activated by an external signal. In this case, it is circulating ACTH. There's a clinical correlation here as well. Ketoconazole, an antifungal agent, can actually inhibit the enzyme desmolase and prevent the entire process we are about to discuss from starting. When desmolase acts on cholesterol, the molecule is converted to pregnenolone. At this point, the molecule can either gain a hydroxy group and become 17-hydroxypregnenolone, or it can become oxidized to progesterone by 3-beta-hydroxysteroid dehydrogenase. You can follow the other steps and see the relevant conversions. A few other points to be made about the reactions here. Stop looking at the screen for a moment and ask yourself, what stimulates the production of aldosterone? If you don't know it immediately, here's a hint. It's part of the RAA system. Got it? The answer is angiotensin II, and if you look back at the screen now, you'll see that angiotensin II stimulates aldosterone synthase, which is responsible for catalyzing the final step in the aldosterone synthesis pathway. Over on the right side, you'll see the peripheral conversions of testosterone into estradiol or DHT. The relevant enzymes are absolutely critical for you to know. Testosterone is converted to estradiol by the action of aromatase, and aromatase inhibitors such as anastrozole are important drugs in the treatment of some types of breast cancer. The enzyme 5-alpha reductase converts testosterone to DHT, which binds to androgen receptors with a 100-fold greater affinity than testosterone. Inhibitors of 5-alpha reductase such as finasteride are used in the treatment of benign prostatic hyperplasia or BPH. More on that in the reproductive lectures. Now let's consider the issue of enzyme deficiency diseases. The three major forms of congenital adrenal hyperplasia or CAH are highly tested concepts. Let's start by asking, why do the CAH enzyme deficiencies lead to bilateral hyperplasia? Well, when one hormone is not adequately produced, the body tries to increase its production by releasing more ACTH to stimulate the adrenal cortex. However, elevated ACTH cannot overcome an enzyme deficiency, so the main effect of ACTH is trophic. ACTH stimulates tissue growth and hyperplasia, not hypertrophy. The first deficiency is that of 17-alpha hydroxylase, which is enzyme A in the diagram. You can see how if the rightward pointing arrows depicting the role of this enzyme are blocked, the only product the adrenal gland can make is aldosterone. Hence, patients with 17-alpha hydroxylase deficiency have high aldosterone levels, resulting in hypertension and hypokalemia, while the cortisol and sex hormone levels are too low. In XY patients, the lack of DHT results in pseudohermaphroditism, people who have female external genitalia but no internal reproductive structures of either gender. In XX patients, we observe the expected female phenotype, but low sex hormone levels result in sexual infantilism. Let's move on to the second form of CAH, 21-hydroxylase deficiency. This is actually the most common of the three forms of CAH. As you can see from the diagram, if there is a deficiency in 21-hydroxylase, noted as B, then the steroid precursors cannot move down the pathway to become mineralocorticoids or glucocorticoids. The only option is to convert to sex hormones, so these patients end up with over-masculinized phenotypes, pseudohermaphroditism for genetic females. Because there is limited aldosterone production, these patients also suffer from hypotension and hyperkalemia. In the newborn setting, patients often present with hypovolemic shock. Lastly, we have 11-beta hydroxylase deficiency. This enzyme is noted as C on the diagram. Similar to 21-hydroxylase deficiency, there are abnormally low levels of aldosterone and cortisol. Both forms of CAH feature masculinization. However, an important difference between these two forms of CAH arises from the fact that 11-deoxycorticosterone has mineralocorticoid activity that is similar, though not equivalent to aldosterone. Excess 11-deoxycorticosterone leads to hypertension as opposed to hypotension seen in 21-hydroxylase deficiency. We've now talked quite a bit about the synthetic pathways that produce cortisol in the adrenal cortex. Now let's discuss the functions of cortisol in the body. One of the most important functions for cortisol is to maintain blood pressure. Cortisol upregulates alpha-1 receptors on arterioles, which biases them towards vasoconstriction. Cortisol is also one of the counter-regulatory hormones along with glucagon, catecholamines, and growth hormone, which oppose the actions of insulin by upregulating gluconeogenesis, lipolysis, and proteolysis. Cortisol is therefore diabetogenic. There are two other functions of cortisol we will mention here. The hormone antagonizes bone formation and immune cells. The latter gives it an overall anti-inflammatory effect. Cortisol is carried through the bloodstream by corticosteroid-binding globulin, also known as transcortin, which is produced in the liver like many other carrier proteins. Additionally, studies have shown that chronic stress induces prolonged secretion of cortisol. Since you already know that cortisol depresses immune function, it makes sense that chronic stress may result in higher susceptibility to infection and cancer.